All right, good evening everybody, and welcome again to the Ultimate Pulmonary Wellness webinar series. Welcome to the Pulmonary Wellness and Rehabilitation Center. Thank you to the American Lung Association, our partners in this series. And I will start with our disclaimer to get it out of the way. Anything you're about to hear for the next hour to 7 hours is our own opinions, so please, anything that we recommend, please clear with your personal physician / healthcare team before going out and trying it. These are our own opinions. Don't go out and say, Noah told us to do it, because I'm not and I will not. We are very lucky tonight to have another super specialist with us. Dr. Anna Krieger is a board-certified specialist in sleep medicine by the American Academy of Sleep Medicine, which is, I guess, a good certification to have. She's an associate professor of clinical medicine in the departments of medicine, neurology, and genetic medicine, and the medical director of the Weill Cornell Center for Sleep Medicine. If you're sensing a theme, I'm thinking she knows about sleep. She also holds board certification in internal medicine, pulmonary medicine, and is a faculty member in the Division of Pulmonary and Critical Care Medicine at Weill Cornell Medical College, and an associate attending physician at the New York Presbyterian Hospital Weill Cornell Medical Center and the Rockefeller University Hospital. Over the past 15 years, Dr. Krieger has been actively involved in patient care, training of sleep specialists, sleep disorder education, and sleep research. She is a Robert Wood Johnson Scholar, a Fellow of the Royal Society of Medicine, and a Fellow and Policy Advisor at the New York Academy of Medicine. The Royal Society sounds fancy. Thank you for being here, Dr. Krieger.
My pleasure. Thank you so much for having me today.
All right, let's get started, ladies and gentlemen, and please feel free to send us your questions, and you can also indicate if you'd like us to hear your voice, which you know we like to hear voices from around the country and around the globe. So feel free to type those in, and we will get started. We'll do about 45 to 50 minutes, and then we'll take questions. So let's start it off nice and basic. Most people think that you're either asleep or awake. You probably know that that's not the case. So if you could just explain to us a little bit about the physiology of sleep, what's happening to us, and maybe the different phases of sleep.
Absolutely. So it's very interesting to see that there are many hormones, we call them neurotransmitters, when they function and affect the brain activity. They're basically are released at different times of the day.
Okay.
So during the daytime, we have a lot of them that relate to alertness. But as the evening time comes, our brain senses the darkness, because we've been on this planet for a very long time.
Okay.
And what happens is that there's a signaling pathway that sometimes can be even be activated by melatonin, and that's why many people ended up taking sometimes melatonin as supplements to enhance the sleep. And what happens from that point on is that a whole cascade of neurohormones start changing. And you get into a stage which we call stage 1. It's pretty much a transitional stage into sleep. So it resembles wakefulness still a little bit,
okay,
but very quiet.
So what are the hormones during the day that are most active?
A lot of the catecholamines, the activating hormones, sympathetic system drive is increased.
Adrenaline, noradrenaline?
Right.
Okay.
Absolutely. And then what happens then as you transition into sleep, you go into stages that we categorize based on the electrical activity. Then imagine all these chemicals are changing the brain cells, and the brain cells are firing at different paces. So we monitor sleep by putting electrodes around your head, and all these electrodes are now sensing electrical activity. And based on the patterns that we see, we can determine if you're transitioning to sleep, again, in stage 1, then into a very stable stage of sleep, we call that stage 2, and then into deep sleep, which sometimes is a misnomer. What we consider scientifically deep sleep is really a slow pattern of sleep. We call that slow wave sleep. And we merge stages 3 and 4. We no longer call stage 4 of sleep.
Okay, gotcha.
And then from that point on, you get back into a superficial stage, and then dream sleep, which is rapid eye movement. We normally call it REM. So that consists of one cycle of sleep, and we have overnight 4 or 5 of those cycles through, depending on how long you sleep.
So
each cycle is a little different.
Okay, so phase 1, phase 2, then we go into slow wave sleep, and from slow wave sleep we go to REM sleep.
Yeah, not directly. We go transitioning back into stage 1 and then into REM sleep.
Okay.
And as the night progresses, each cycle will have less of this deep stage, less of the slow wave sleep, and more of the REM sleep.
Gotcha.
So it, again, is a very active process. You know, back in the 1500s, we felt that sleep resembled death almost, right?
Okay.
We felt, people, nothing happens to the brain during sleep. Now we know that the brain is super, super active during the night.
Okay, and what are the characteristics of the different stages? So if somebody comes in and they're in stage 1 sleep, what would we expect to find?
So at night, for us monitoring somebody or watching someone during sleep, we don't really know what stages they are. There are some changes that can resemble different stages, so without monitoring we can't be accurate. We could guess, let's say, rapid eye movement, the way it was discovered is because someone was in the laboratory and they saw the eyeballs rolling with the eyelids closed. And that's how the name came about. And that tends to be a very active stage for dream-related content, let's say. We tend to dream a lot more during that rapid eye movement. Now stage 3, which is this deep sleep, it's a stage where sometimes we can act out, we can sleepwalk, we can sleep talk. A lot of this behavioral activities that sometimes you see in the young children as well comes out of the deep stage of sleep.
But dreaming comes in which stage?
Rapid eye movement.
REM
mostly.
sleep.
Not exclusively, but mostly.
How much sleep does the average person need per day?
Very good question. So there is not a uniform number. It's very hard for us to say what a person really needs. There are genetic bases for sleep duration. There are also changes that depend on your own physiology. Some days you may be busier and more active physically and you may need more rest. But what we generally recommend for most American adults, based on the data that has been published, is that between 6 and 10 hours. Less than 6 is not adequate. More than 10 hours seems to be a bit too much. So if you average that out, perhaps 7.5 or 8 hours, but it's very hard for us to pinpoint. Each person, however, should know how much sleep they actually need. Because if you know you have your schedule, perhaps not nowadays, people are busy working, but during vacation times and all, they might be able to identify that after sleeping 8 or 8.5 or 7.5 hours, they get out feeling well and well rested.
And what about, can you get too much sleep?
Well, you can't force the body to sleep too much. So sometimes people make the mistake, let's say they may have a sleep fragmentation or insomnia, and what they ended up doing is extending their sleep period. They try to go to bed a little bit earlier in order to catch up. So once you extend the sleep too much, it ends up being fragmented, almost like elastic band. If you overstretch it, it kind of breaks apart. So
it's not as good quality sleep.
No. So most people can't really artificially sleep more unless you take a medication. The brain won't sleep more than what it really needs to.
Besides the brain and the neurologic system, I know that sleep has a lot to do with the respiratory system and the cardiovascular system. So the overwhelming majority of people that we're talking to tonight do have some type of respiratory disease or cardiovascular disease. What are the things that they need to know? So let's start with, let's say, somebody with COPD or restrictive lung disease or asthma. What are the things that they need to know about sleep and how it affects their respiratory system?
It's very important to remember that when we go to sleep, a lot of the voluntary control of breathing is being withdrawn. So we can't, like here we're talking and breathing at the same time. I know if I talk too much without taking a breath, I'll be short of breath. So I can voluntarily coordinate that. During sleep, we just have a different process, which is just the involuntary control of breathing. So the many respiratory conditions, cardiovascular conditions, then can become a lot more visible during the night, because during the daytime we're able to compensate.
So the defects become more, so you mean the actual cardiac problems or pulmonary problems are more apparent at night?
Oftentimes. We have several manifestations. Let's say people with COPD, sometimes their oxygen level during the daytime, they might be able to compensate unless they exercise. And during the night we can see there is really a drop in oxygen saturation. Because the other big phenomena for the breathing predominantly is that when you go to sleep, the muscles tend to be more relaxed.
The respiratory muscles?
Absolutely.
Well, all
the
the muscles.
The airway muscles. So a lot of problems may appear at that point. For people with heart disease, sometimes we see that they have a different pattern of sleep, which we call Cheyne-Stokes breathing. It's a type of sleep apnea. And we only detect that either during exercise or during the sleep.
So what are the issues that you see most common in your practice that people at home should say, hey, maybe not to make you a hypochondriac or anything, but to say like, hey, this is something that I should be aware of, maybe I have this, or what are the warning signals?
Well, one of the most prevalent conditions is snoring. We know many people snore, but snoring can be, I can't say benign, but it's a condition that sometimes is an indication of sleep apnea, but not necessarily means that somebody has sleep apnea. So very loud snoring or snoring that is interrupted by gasps or by quiet periods is actually the snoring that concerns us the most. Because if somebody is snoring continuously during the night, in and out. It just means that they are always breathing, and that's how you hear the snoring.
Okay.
We get concerned when the snoring disappears, which means that they may not be breathing.
Gotcha.
So that irregular, loud or no snoring intermittently happening during the night is of concern.
Is that something that's very prevalent in people with COPD?
It is, but not necessarily more than the general population.
Okay.
It's very prevalent in men and
Uh-huh.
after age 65 as well.
Men after 60. And what about, like, I guess the restrictive diseases like IPF, not any more prevalent than the average person?
Well, what happens with the other lung diseases is the problem with the muscle activity. So again, remembering that during the day you can use a lot of the muscles to compensate and try to inflate the lung a little bit more to catch up on your lung volumes. During the night, as the muscles get very relaxed, you are unable to do that. So sometimes patients that have reasonably well compensated lung disease, restrictive lung disease, or IPF, during the daytime, during the evening, we can see that there are desaturations and respiratory changes that become important.
Gotcha. Why do a lot of pulmonary patients who don't wear oxygen during the day, and it sounds like this might be part of the reason, but why is oxygen recommended for a lot of people at night who don't wear it at any other time during their day?
Because of the same mechanism. So the muscles start to relax, so the lung volume decreases, the airway muscles are very relaxed as well. So the effectiveness of the ventilation is decreased at night.
Gotcha.
So you can't expand the lungs as much.
And is there a certain amount of oxygen that's typically prescribed for somebody at night?
Very good point. The American Lung Association and other ACCP as well, which is the American College of Chest Physicians, have had committees in the past to look into this because there has never been a very large trial to identify what is the best predictor during the daytime that will tell you how many liters of oxygen a person needs at night.
Okay.
So it's very empiric nowadays. Most people, we tend to start very slowly because people with lung disease, we're very afraid to give them too much oxygen because otherwise you cut down the respiratory drive. So the idea is to start very slowly, sometimes half a liter of oxygen.
Really?
And then we can increase as needed. It's very interesting from our perspective, from the sleep environment. We monitor people at night. So we can see all the data in the screen. We can see the oxygen level, we can see the respiratory rate. And sometimes you see very low oxygen levels, let's say 84, 83%. And you give half a liter of oxygen, that's just enough to get them at 89.
Really? It's hard to believe that would do it. Now, when you talk about giving too much oxygen, are you referring more so to like the CO2 retainers, or is that for anybody?
Yeah, mostly the CO2 retainers, because we're always concerned about CO2 narcosis, which is then the event where the brain basically gets overly sedated because there's too much CO2 available.
Gotcha.
And it cuts down the respiratory drive. So we have to keep that balance that most people that retain CO2 would have other chemical buffers in the system, and they are well balanced with
Okay.
that, and oxygen can actually disrupt that balance.
So let me ask you this, because this is something that I see people talk about a lot and I see it written about a lot. There's a whole lot of talk, and I see it from sometimes doctors, but more so respiratory therapists, paramedics, who say they're afraid of over-oxygenating a patient because they, and if I understand it correctly, so you have the CO2 retainer who's chronically high in CO2, and therefore they switch over to hypoxic drive, right? Because otherwise they'd be constantly being forced to breathe. But in all of my years, and I've never seen anyone sleep during this, but in all my years of EMS also, I've never seen somebody stop breathing because, or even when we exercise people, we will often give people 100% O2.
Right.
And people say, well, you have to be careful because they're going to stop breathing. And to me, I've never seen it happen. And I feel like it's because if you stop breathing, we're going to say, hey, take a breath. But how common is it during sleep? Because that sounds scary.
Well, it's very possible. We don't know how common it really is because we're not at home monitoring people, but what we get to see as patients when they come to the emergency room is that progressive use of oxygen, sometimes people are very overcautious and they want to see 100% on a pulse oximeter that now they can buy, it's readily available.
Right.
That they shouldn't shoot for that as a goal.
What number should they shoot for?
So what we normally recommend is a level above 88. So between 88 and perhaps 92% would be adequate. We don't want to over-oxygenate them because then what happens during the night, back into your question, is that we start cutting down the respiratory drive, and perhaps in one night we don't cause a lot of damage, but imagine 10 consecutive nights of 8-7 hours each of slowly increasing the CO2 level, because if you have enough oxygen, the body would perhaps say, why do I need to breathe? We have oxygen. And that's the mechanism, and then it slowly gets progressively worse, and eventually they come onto the hospital because they say, sometimes brought up by a family member, saying my relative slowly over the past week has gotten a little more quiet, and then he's slowly more confused, and now he just sleeps all the time.
Really?
And that basically means that the brain's not functioning.
But if they retain CO2 at night, let's say, they retain too much, aren't they going to blow that off during the next day?
Well, but they have lung disease, so they can't fully compensate.
Gotcha.
And that's the major problem on keeping the balance. I think every time we look into the body function, I like to imagine, whoever has had chemistry courses, it's always that equilibrium, and you need to be careful because every intervention that we do, even if it's a well-intended intervention, will shift this equilibrium, and it may cause downstream a side effect that will be a problem. And that's the concern with too much oxygen, that will create this cut down and drive, and then during the day they are already debilitated and they can't, like we probably would be able to give us 100% oxygen, it will compensate during the day even if it cuts down our drive. But if you come in with limitations, it will happen.
Okay, and for the patient who, let's say, lives alone, because I know a lot of our people do live alone, how would they know? Like I know if you're sleeping next to somebody, they'll always say, oh, my husband stops breathing in the middle of the night and then he wakes up. How would somebody who lives alone know if they're stopped breathing, and when should somebody go in for a sleep study?
Right. Majority of patients that have very significant breathing problems, they tend to have daytime consequences, either being that they wake up feeling unrefreshed, or you're drowsy during the day, you start falling asleep at meetings, you feel that the sleep is no longer as restorative as it once was.
Okay.
Or let's say people have gained weight, and then that's when they develop perhaps a little more snoring and dry mouth. So there are usually some other daytime symptoms associated. Very, very rarely we have people that have significant degrees of sleep apnea that really have no daytime symptoms. Sometimes they present that way, saying, someone told me to come and check because either I share a room with somebody or they mention I might have sleep apnea, because people are aware of this. But once they get treated, they look back and they say, oh, I never realized, but I indeed was tired during the daytime.
Well, you also hear sometimes people crash their car, fall asleep at the wheel.
That's a big issue, and that's very common. We look at, accidents. We just had even another train accident, and people keep investigating and seeing, we're all overworked, as a general population. We're mostly sleep deprived. So if you add to that a possible sleep apnea, then it leads to daytime issues and performance.
Gotcha. So let me ask you this. So a patient is sitting at home, they're saying, you know what, I am tired during the day, but I have lung disease or I have heart disease and I'm not that active. How, or maybe there's not a way other than a sleep study, but how would somebody know the difference between I'm tired because I have a chronic disease and I'm inactive, or I have sleep apnea? And I mean, it really is not the patient's responsibility to say to the doctor, hey, should I have a sleep study? But do most doctors think of this, and when should they?
Well, not everybody, because I think there's an issue healthcare-wise. People are very constrained by time, and sometimes people, particularly with chronic disease, there are so many issues to be addressed that not necessarily every time and every visit, every doctor will remember to ask about a sleep problem. So I think it is important for patients to be aware, and I think the patient is the best advocate for their own health, in honesty, and that's why I love what you're doing in order to educate people, because the more people know, the better they'll be able to feel. So feel free to discuss that with your doctor, is what I usually tell patients. And there are some other monitoring devices that the doctor may recommend that may not be as invasive, not as invasive, but as cumbersome as a sleep study is in a laboratory. There are wrist held devices that can be worn at night to monitor oxygen and heart rate, that the data is all collected. You could use that for one or multiple nights and then analyze the data in the software to identify trends. Even if it's not directly measuring breathing, it is indirectly telling you how
you're getting oxygen number, right?
Exactly.
Okay. Sorry, that's the Pulmonary Center ghost. How can people get a better night's sleep? Because I know a lot of people are sleep deprived. And I'll tell you this, I have we have people on Facebook. I see people all the time in the middle of the night, and I know you see me in the middle of the night. And because people are sending me questions at like 2, 3, 4 a.m. So people are up, and some of you are in different parts of the country, but what is the healthy night of sleep, and how can we get a better night of sleep?
Well, I love this question because, again, we have the power to improve our sleep. So that's the most important thing. We need to remember that good habits go a long way. For many years, we've been now focusing on nutrition and exercise. I think another important part of us to focus on our own health behavior is to focus on sleep. So basically, we start by allocating time for sleep, because what happens to most of us, has happened to me many times, you try to squeeze time on your day, you're very busy, and what are you going to steal time from? We already don't stop for lunch, we barely have time to use the bathroom, we don't drink enough fluids, so we steal from sleep. You schedule a late flight, you schedule a late meeting, you have work to do, you bring them home, sit in front of the computer. So we have to be very proactive at creating a more kind of sacred space for sleep. So that period at night, it should be more or less the same schedule every day, because the body functions with a circadian rhythm, which means approximately a 24-hour rhythm. Again, we've been in this planet for very long. We've adapted to that.
Okay.
The brain has cells that actually track time, and they have clock genes that track time as well. So we have to be very mindful that you can't one day sleep from 12 to 8 in the morning, then the next day from 2 in the afternoon until 5. You have to try to synchronize that clock.
So try to go to sleep at the same time every day, or in the same zone every day,
and wake up
and try to wake up at the same time every day. Okay.
Right. For some people that may be very sleep deprived, we say it's okay to catch up once in a while with sleep, but we don't want people that are chronically trying to catch up with sleep.
Okay.
So we need to respect our body physiology. Know that nothing can replace sleep. We have medications, energy drinks, and all that some people consume, but they can't really replace sleep.
That's wine, not an energy drink. I saw you look at that. It's not an energy drink. Okay. So you can't get it back.
No, you can't.
Okay.
But the body is very resilient. So the same aspect that would happen with meals, let's say if you skip the meal today, or you can't fully compensate for all the food that you should have ingested in the past because you skipped meals. Thank goodness the body is great at this, and you're able to then restore your physiology even if you don't have to pay all your adaptive sleep that you've accumulated over the years. So that's the most important role. And then everything else comes from surrounding that. So once you allocate that schedule and the period for sleep, then you look at the activities you do before going to bed. Are you bringing your computers to bed, all your electronic devices, are you bringing your worries to bed? What type of environment you create before going to sleep? Because not even the computers can really shut down in a few seconds. So we expect, particularly nowadays, everything is immediate. You expect to hit the pillow and fall asleep. But that's really not normal. Normal is for the brain to go through a process that slowly will get into sleep.
Okay. Is this what's called sleep hygiene?
Yes.
What is meant by that term, sleep hygiene?
It's kind of a strange name. I've had patients come and say, I have actually very good hygiene. I don't like it.
Right.
So I talk about more behaviors that are associated with sleep. So keep a good environment at night. For the half an hour before your schedule, bedtime, avoid electronics. Try to use, they even have some goggles that you can wear that block a lot of the wavelength, the blue wavelength that electronic devices produce, because it's pretty stimulating.
Okay.
So people may be able, if they have to work on computers just prior to going to sleep, they can use that. But in general, so you shut off the devices, put them away. You should find time during the daytime to use them.
No Facebook right before bed.
No, unless some people like to watch movies, let's say. The television is not as bad as an electronic device near you, but we don't want anything that is stimulating, because that's the time the brain tries to quiet down.
Why is that? Why would the TV be not as bad as?
Because they concentrate the energy and the light that those devices emit are more concentrated on the blue wavelength spectrum of the full spectrum of light.
So it's not an emotional thing. It's not that I'm waiting for that message from so-and-so or...
As well, because the television, you don't really have instant communication with the television. With all the other devices you can. And sometimes people feel so attached, and they develop a relationship of sometimes which is a bit addictive with the device.
Oh, I know. I'm in that zone, and when I actually on the weekend I shut it off for the first time while I slept, and I was so happy. It was like so much better sleep.
Right, quality of sleep, absolutely. So people need to focus on that. So timing of sleep, the quality of sleep you get, and then the duration of sleep. And you always need to shoot for what you mentioned earlier, perhaps 7.5 or 8 hours, but it's very individual.
Can you talk a little bit about, let's say, sleep aids? So for the person who comes in, they don't have sleep apnea, they just have a hard time going to sleep at night. What are some of the things that are available to them?
The first step is to identify the reason for that.
Okay.
Because insomnia, let's say, which is more or less what you're describing, it can be a very large bag of different diagnoses. So many things can fall into the spectrum of insomnia, let's say. One reason could be somebody that has a change on their face. They may be more of a night owl.
Okay.
And the body may not be ready to fall asleep until midnight, but they're trying to go to bed at 10. So
Okay.
that's sometimes one scenario. Another scenario could be people that may have some movement issues or restless leg syndrome type of activity.
Okay.
That prevents sleep from coming because the body feels activated. Another scenario, we spoke about the electronic device. Maybe they are exposed to so much stimulation before going to sleep, the body and the brain is not ready to fall asleep. We have other patients that worry a lot, and they feel that their day is so tightly packed that the only time they actually have to worry is when they finally lay down in bed. And we all need time, not necessarily to worry, but time to decompress and to go through our to-do lists and all. So depending on what are the underlying issues, then we break down to addressing that. I believe that to be much more efficient than just writing a prescription for a medication. We can easily sit there.
So let's look at the behavior first, right? Let's look at the behaviors.
Always.
Okay. And what about the patient who says, you know what, I just can't be without my phone when I sleep? What if somebody calls me? What if my kids call? What do you say to that person?
So we create backups. Let's say we didn't have those 20 years ago, and we all survived.
Right.
So we have, sometimes people say, well, I don't have a landline. I say, so get a landline. Leave a landline in there and put your electronic device and tell people for emergency. We do that in the hospital. I'm on call for the sleep center every third week, and I'm on call for that whole week. They call my landline. My husband doesn't like it, but it wakes him up.
I'm doing
But it's
that.
the
That's a good
landline.
idea. That's a great
And
idea.
I know that's the emergency line. At night, that's where they will find me.
Okay, so basically we're looking at behaviors. Let's talk a little bit about medications and sleep. So if you look at most of our pulmonary patients, they're going to be on steroid, steroid, anticholinergic or antimuscarinic, and a beta-2 agonist, right? So what is the impact on? Let's start with the inhalers. What is the impact on sleep?
So the inhalers can have two major impacts on sleep. One, sometimes they can be a little activating, so they cause a little bit of agitation sometimes after using. The other impact is that they may not last for the whole sleep period.
Okay.
So once they wane off, people may wake up feeling more bronchoconstricted and have a little more shortness of breath in the middle of the night, so they may need to have a repeated use.
Okay, so what are there any medications that people should avoid, let's say, within a couple of hours of sleeping?
I would say medically, take whatever medications they have been recommended to take, but don't add things such as alcohol, because alcohol can affect your breathing and it can actually fragment sleep. Many people have over the years felt that it was okay to drink, sometimes drink heavily before going to sleep because it helped them fall asleep.
Uh-huh.
But once alcohol gets metabolized, the rest of the night has a very, very fragmented sleep. So more than offsets any potential benefit that alcohol may have into getting them to fall asleep.
So no alcohol within what time period of sleep?
2 to 3 hours before going to sleep.
Okay.
And we also mentioned spicy meals and foods. Also, if people have late meals, that can have a big effect on sleep.
Okay, so no late meals, and also, I would assume that would have a big impact on breathing as well.
Absolutely, because then you may have more reflux, which can then trigger more respiratory issues, more wheezing, basal airway issues.
Gotcha. What about the cardiac meds, or anything in particular that we need to know about?
So cardiac meds, there are two medications that can be a problem. One are the diuretics. Again, talking to patients, let's say Lasix, which is a medication that, as the name say, lasts 6 hours. But many people ended up taking that in the evening because they're too busy during the daytime.
Right.
You don't want to interrupt your work schedule or the activities to use the restroom. But if they take that at night, they are doomed to have to wake up and use the bathroom at night.
Gotcha.
So most people that can't take the Lasix during the daytime or any other diuretics, I tell them as soon as you get home from work, take it. So at least the major effect of the medication will be done by the time you get to sleep.
I think a lot of people have that problem is they don't want to take Lasix or furosemide in the morning because they're like, no, then I'm going to have to find a bathroom every 5 minutes. But then they come home and, as you say, they're waking up all night.
Right.
But I mean, that's a tough drug anyway, because that's a drug where you're like, I'm going to take this pill, and then for like the next 6 to 8 hours, this pill is telling me what to do, where I can go, how long I can be out for. What about prednisone?
Well, prednisone is very interesting because it can have different effects in different people.
Okay.
And sometimes it can be really bad for sleep. Some people can feel very activated and they may have insomnia just because of the use of prednisone. So they need to be mindful of, again, it may have a neutral effect on the sleep, but it may really worsen sleep.
I recently was on I did an 8-week course of prednisone, because not for COPD obviously, but I picked up a little bug in the Bahamas. I slept 45 minutes a night, and I loved it. Most people hate that, but for me it was like such a productive time period.
Wow.
But then after I stopped it, I was exhausted.
Right, because then so the mechanism that gets you to not sleep is activating to the point that you feel during the daytime you're Superman.
Yeah, it's got its pluses and minuses.
Right.
You mentioned restless leg. Can you talk about that a little bit? Because I think the 3 complaints I hear with the legs a lot, or the 2 complaints, I hear people who talk about cramping at night, particularly in the calves, and restless leg syndrome.
Right. So restless legs is actually a pretty common condition that is underreported because most people don't really, in the healthcare profession, don't really ask patients about that. But people need to be aware if there is this uncomfortable sensation, particularly when you lay quietly in bed, that tends to happen in the evening. So during the daytime, it tends not to happen.
Okay.
Only when you're at rest. And if you start moving, the symptoms tend to get better. And if that is present, discuss with your physician or your healthcare provider, because there may be some assessments, blood tests that may be done to determine if sometimes people may have some deficiencies, minerals or vitamins that can be replenished and alleviate symptoms.
And that causes restless leg?
It's associated with the symptoms development. We don't really know exactly what causes restless legs.
Okay.
We know there is a big overlap. Some people have diabetes, they could have restless legs. Women during pregnancy could have restless legs. Patients with neuropathy could have restless legs.
And what does it feel like? What do
insomnia.
people report when they have restless leg syndrome? Because it sounds like your legs are moving or...
In some cases it's cramping. Other patients, they say more of a crawling sensation. Some people have defined as more of the Charlie horses.
Okay.
So, again, there is a lot of different perceptions of what is happening, and people may describe it in a different way, but it tends to be all part of the same.
And are there treatments for this? What are some of the treatments?
So sometimes we supplement vitamins and minerals if needed. Other times we then talk about medications. And most medications are medications that will not be necessarily sleeping pills, but they would be medications that will quiet down the nervous activity.
Gotcha. And what are the vitamins and minerals that people most often lack? Because a lot of times we'll say, and it seems to be a lot with the patients who happen to coincidentally be on Lasix or furosemide, but a lot of times we'll say I have 6 ounces of Gatorade, and that sometimes gets people...
Right. So electrolyte imbalance is something that they need to watch for. Calcium, magnesium, potassium. They need to look sometimes vitamin D levels. That has just been a recent study published looking at replenishment of vitamin D that led to improvement in restless leg symptoms. A lot of literature looking at the storage of iron in the system, so not necessarily your iron levels, but the storage that is measured through a different blood test. And if that storage is decreased, supplementing patients with iron may improve symptoms as well.
Oral iron?
Oral iron, sometimes even IV, depending on their
That's what I was going to ask. Is an infusion more effective? Or
It is more effective, but as with any infusions, it has a little more risks.
Gotcha.
So we tend to try the oral route first.
And what about the idea, I hear people talk about this all the time, of putting a bar of soap at the bottom of your bed. And I hear this a lot.
Inside the sheets. Yes, there is a lot of say about that, and it's very interesting. Just the other day, I had a patient bringing me a book with several kind of home remedies. You smell onion, and that in the middle of the night, that
smell
will
onion?
back to sleep.
Okay.
And it's really fascinating to see. I think, again, when you look into nature, all the chemicals that we have in our body are also present outside. So perhaps there is some other linkage into this, and we just haven't studied. So I can't say.
It's a good study, though, right? Is there you don't know like a particular brand that you would recommend over another, Ivory or Dove?
What I've read, again, not in the scientific literature, is that probably any bar of soap would do it, and it doesn't last forever. I hear from patients as well. They say they need to replenish the soap after once in a while.
Okay, good to know. Good to
But,
know. Let's talk about some treatments for sleep apnea. So what are they? Who needs them?
So the treatment of apnea is based on the severity of the disease mostly. So
Okay.
we'll start with CPAP, which is what most
Can you just
people
just
are.
define apnea?
Oh,
Because I think a
sure,
lot of people don't
absolutely.
really know what that means. So what happens to the patient physiologically?
So basically, during a sleep, during the daytime as well, so we breathe through our nose predominantly. Some people as well breathe through the mouth. But both are joined in the back of the throat. So if you were to draw a line just behind your ears, so that's where the airway sits, and then it comes up to the front where the trachea sits. During a sleep, predominantly, if you lay on your back, the mouth has a big muscle inside, which is the tongue. The tongue may be pulled backwards. And then that space in the back that was the airway is now being pushed in.
Okay.
So imagine that you're breathing through a straw at night, and our airway is quite small at night. As people gain weight, they have respiratory problems, they may have a tongue that is falling back, the airway may narrow down. So the way we monitor that during the night is we monitor breathing through the mouth and the nose and monitor your oxygen. So we recreate a cycle almost the same way as many people that have had pulmonary function tests. You can see there's like waveforms that are generated. So we monitor that waveform anytime people breathe in and out. Once we detect that that waveform is very abnormal for more than 10 seconds, we call that a respiratory event.
Okay.
And there are different categories of respiratory events. There are people that the airway is just getting pinched to the point that the breaths are half of their normal amplitude. And other times there's just no air going through.
Does that mean it's not as deep or less is getting in? Like they're taking a deeper breath but less air is getting in, or they're not breathing as deep?
They're not breathing as deep and less air is coming through.
Okay.
So what happens is that those shallow breaths we call hypopneas, which hype apnea, so it's just a small breathing. And when there's no breathing, we call apnea.
Okay, so
And-
hypopnea is less breath, apnea is no breath.
Right. And what we do for 10 seconds, it has to last at least 10 seconds, which is more or less 3 respiratory cycles. Once we detect that, we keep on counting how many times we have at least a 10-second event overnight. And we divide that by the duration of sleep.
Mm-hmm.
So what we're left out with is an AHI, which is an apnea-hypopnea index. So it's the combination of all the events we saw divided by the total duration of sleep.
And this is all measured by computer?
No.
No,
human.
how is
Yes.
humans? So
Yes.
somebody's sitting there.
Visualizing,
Wow,
and that's why the
okay.
sleep studies ended up being cumbersome because, of course, for the patients they have all this monitoring, but on the backside we have the technologists going through all the breathing abnormalities and quantifying that. So once we look into this index, everybody has a little bit of an abnormality during the night.
Okay.
But we create cutoffs the same way that we have cutoffs for blood sugar, for blood pressure. So epidemiologically, through large studies, we have been able to look at people that have stopped, that have those respiratory events over 30 times an hour, have worsening cardiovascular function.
Increased risk of heart disease?
Heart disease,
Arrhythmia?
arrhythmias, strokes. So the idea for those patients is really to be treated, and that's the group that we focus on recommending CPAP type of machines. So those are the equipment that ideally they would serve as a mechanical spleen to the throat. So imagine again visualizing that airway. If I'm laying back, it's almost like a circular airway, not quite, it's a C. So imagine if you had a flat tire and your car is still heavy, the air is not going through that, so you inflate with air. The idea with CPAP is very similar. It's just you wear a little mask attached to a machine that is an air compressor, and the air compressor increases the pressure a little bit. It's less than 1 atmosphere. It's easy to tolerate in most patients. And by keeping the circuit sealed, by putting a mask either into the nose or around the nose, it will just generate an opening on this back space of the throat and allow you to breathe normally.
So it's giving a positive air pressure, and that's what holds the airway open.
Right.
You make it sound very simple, but patients often report, you say, do you have CPAP? And they say, yes, but I never use it. Maybe they don't tell you that.
Well,
and I'm not
we
saying all
want to-
patients, but how do you, I mean, a lot of patients report that the mask is uncomfortable, or they go to sleep with it and they wake up and it's off.
Right.
It's like I used to do that with my braces at night. I'd go, I
Right.
put it in, and then I go,
Well, so I think there are some factors in that. We monitor their compliance, which is that usage of nightly. And now there is equipment that allows you through the internet. Sometimes I do that on the weekends. I have my list of patients and I go through to make sure everybody is using. So reporting is not as much of an issue. I think the major issue is not everybody with sleep apnea should be on CPAP. Not
Okay.
everybody is a CPAP candidate. Not just because you were labeled with a diagnosis means equals to CPAP. People that have less severe disease can be effectively treated with other options. Now, if you have significant disease, of course, we want to work and try to find a CPAP equipment that works well. And that often leads to issues of comfort. So there are different interfaces. The same way that people have different shoes. Some people like sneakers, others like dress shoes, and others wear any types of shoes. You need to find an interface that will sit on your face that is comfortable enough. Because there are issues of comfort. We are in the sleep environment when we monitor people during the night. I always tell my patients, please tell the technologist or whoever is monitoring you at night if you feel uncomfortable, because we can monitor leakage in the system, we can monitor oxygen, we can monitor your breathing, but we cannot monitor comfort.
Does a patient have a right to go back to their company and say, hey, this isn't working for me, give me something different?
Yes, so many insurance companies allow patients to change a mask within that first 30 days free, but I think it's important for them to talk to their healthcare provider as well, because that beginning process is very important. If you develop a bad relationship with the CPAP machine from the beginning, it will be very difficult to make it happen and to work in the future. But many of those patients can be rescued because we don't want to leave them untreated.
Of course.
And there are some people that don't tolerate. No matter what we try, there's sometimes some other issues related to that, and we'll work to get them at least partially treated.
I've seen a few things that look like dental. They look like a mouthpiece or something.
Exactly.
Are those as effective?
Yeah, so what we're talking is, remember we spoke about the more severe cases, then we have all these people in between.
Okay.
They might have borderline increase in the index, but they may not qualify for CPAP because they may not be severe. So they have a wide range of options. They could still choose CPAP. Many people say, oh, I don't mind, I can use that, I'll be okay. Others would say, I'll do anything before getting to that point. So we call those mandibular appliances, so they call a mandibular advancement device. The idea behind that is, again, remember when we talk about the airway narrowing down in the
Right.
back, if you reposition your jaw forward during a sleep, the tongue is inserted right in here. You pull this big muscle out of the way and you increase the size of the airway.
Gotcha.
So many patients that wear those devices, and they have to be manufactured by dentists that really are versed on this.
They're one-to-one, right? They're not like something, because I've seen them in the magazine of an airplane that I've been on.
Right. So there are some that people are supposed to put in hot water and mold it and then try to use. If people have that at home, at least will give them a sense of what it feels like.
Mm-hmm.
But it really should be done by a professional, because there are issues. The idea of the holding of the jaw, remember the jaw is pretty strong. You will be holding the jaw on your upper teeth, so that can cause the dental motion as well. So you have to be very careful and be very well monitored for that. There are other patients that perhaps they have nasal issues. They have a lot of congested airway passages in the nose, and they may have, we call this the turbinates, which is that concave area that protects the sinuses in the nose.
Mm-hmm.
Sometimes they are swollen, and we can use nasal sprays. They can be seen by an EMT doctors. Perhaps shaving that could also lead to some relief.
Interesting.
And there are even very more elaborate surgical procedures that can even cut the jaw
Mm-hmm.
and advance the jaw going forward and the tongue.
That doesn't sound like.
It doesn't sound very appealing, but there are some patients that have craniofacial features where they have a very small jaw, and that's how they are formed.
And is that a
That's
permanent
all.
fix then?
It could be a cure for apnea.
Interesting.
But again, it's a cosmetic change, it's a big procedure. So I always recommend for people, if at whatever level they are, if they feel they have sleep apnea and it hasn't been fully treated or fully addressed, there are options. So talk to your doctor and get the right specialist that they will be able to discuss that.
You're totally biased on this, but how important is this in the scheme of cardiovascular and pulmonary disease? Because I've heard people say things like, you know what, that's just one other thing I have to do between my nebulizer and my inhalers and my exercise and my breathing techniques and my chest. How important, like what are the things people should worry about if they're...
I think it's very important. Again, I'm totally biased, but I've been doing this for 17 years now, and I've had patients, I have several people well in their 90s with several chronic conditions that I think one of a recent patient of mine, I've been seeing him for about 5 years. He came to me when he was 92. and people had given up, saying, listen, he's having all these problems. The doctor just said, can you please try that? I have another patient that came, she was 85 or so, and she has been very well treated now for 7 years. I really believe we can help people, and we have all these examples to see. But there's also a lot of data in the literature that points out that it will decrease the risk of developing complications. And that's why what we want to do is to work with the patient and say, we want to team up and do something that will improve their health. So the cumbersomeness of the treatment will be so diluted because they will feel so much better during the daytime.
Gotcha.
Of course, if they don't see or don't really have any benefits from it, we do have some patients that we say, listen, it's okay, we don't want to create more worries and now make them lose sleep over this. But in most cases, we have been quite successful at trying to identify a form of treatment that works well for them.
And for a lot of people, their lives get much, much better in response to treatment.
Absolutely. We have patients that have to have ablations, they have arrhythmias and recurrent arrhythmias, and the low oxygen at night is triggering this. Patients, again, that they have CO2 retention and the COPD is really acting up during the daytime. People still are functioning and they're working, for a whole lifetime. No longer we have necessarily people that just retire and do nothing after a certain age. So if you can restore the quality of life, I think it's really dramatic.
Okay, one last question. Can you tell us just the difference between CPAP and BiPAP, and then we'll go to some audience questions.
Perfect. I was going to get into it. I'm glad you asked.
Okay.
Because the idea between CPAP is just to provide that positive pressure to open the airway, and the patient breathes independently.
What does CPAP stand for?
So
Let's start.
CPAP is continuous positive airway pressure.
Okay.
So it just provides that positive pressure. Patients breathe independently. There's no mechanical breathing for them. There's no added oxygen.
Okay.
It's room air oxygen. Now the BiPAP mode is a mode where the pressure now oscillates. The machines now have very, very good sensors. So the machine is sensing that you're breathing in and is increasing the pressure on the airway. And the idea of doing that is that it will help you enhance your breathing. So a lot of people that retain CO2 ended up using the BiPAP mode. Now there are even fancier modes. We have ASV, which is another type of mode, which is a fancier BiPAP machine, if you will. And they use different algorithms to monitor your breathing and determine all the pressure settings. So the important part of this is that even if the machine and the equipment looks the same, there are different software that can be installed by the company.
I see.
And would allow the patients to normalize their breathing at night.
Okay.
But all of that has to be done, in an asleep environment, in a center, because very rarely on the more complicated software, we can just send a patient home with the complicated software and allow them to be able to adapt to the machine without assistance. Because the settings, even on the machines that can automatically determine the settings, we have to provide some guidance and some range.
There has to be some adjustments.
Right.
And basically, so when the BiPAP, is that responding to the patient's breath?
Yeah, so it senses when somebody starts to breathe in, the pressure would increase, and when the respiratory cycle is ending from the inspiration, the pressure declines, and then you breathe out against less resistance.
So it's not going to be pushing. I think a lot of people have this idea that they're going to be breathing out and the machine is going to be pushing air down their throat. And so I think a lot of times in people's minds, it sounds much more, and the word I hear a lot is claustrophobic. And I think it sounds a lot worse than it probably is. I don't know, I've never...
Well, technology has advanced dramatically. So over the past 5 to 7 years, a lot of these comfort features have been added to the equipment. So no longer, even on a traditional CPAP machine where we talk about this constant positive pressure, the pressure may not even be totally constant. The machine still senses that you're trying to breathe out, and it may decrease the pressure sometimes by 1/3 of a centimeter of water, sometimes by a full centimeter, 2 centimeters of water, whatever is needed for comfort. And all those settings can be adjusted as well.
Good to know. All right, let's go to some questions from the audience. I have one that I received a little while ago by email. This is from Amber, and it's right on target with what we're talking about. If you're a CO2 retainer and you're using a CPAP instead of a BiPAP, what kinds of problems can you expect?
Well, perhaps none, because it depends on what the underlying problem is. So let's say if you're a CO2 retainer, but you are stable, retaining CO2 and your CO2 levels during the night are not going up, sometimes just opening the airway and restoring normal respiration is enough. You don't need to Because the idea is that you don't always use the machine to overcompensate people during the nighttime. There are some cases in the hospital where we can see people start retaining CO2, and then at night you put them on the machine and you compensate for the daytime. That is pretty applicable to patients that have lung, more neuromuscular function loss. So those patients, you want to ventilate them at night and allow them to function during the daytime. So it may be totally fine to
Maybe
use
no
just a
problem at
CPAP,
all.
maybe no effect.
Is there anything that somebody with CO2 retention has to be more, or anyone in general has to be more aware of with CPAP instead of BiPAP?
Not necessarily. I think it's just the issue of feeling well the next day, so from the patient's perspective, but there shouldn't be any deleterious effect that we need to worry about.
Good. Okay. Question from Larry. I am taking Lyrica for nerve damage problems. It has also improved my sleep greatly. I sleep the entire night regularly. I tried quitting the medication once and had great difficulty sleeping. I'm still taking Lyrica. Is Lyrica addictive, and what other sleep problems could it cause?
I would discuss that with your doctor, because I think Lyrica can be very helpful if there is restless leg syndrome, let's say. We have a lot of patients that use Lyrica or other medications similar to Lyrica. Lyrica is pregabalin. There is another medication, gabapentin. They all work in the same system, and that enhances the deep stages of sleep that we spoke earlier on, and it can also relieve a lot of the cramping activities. And I wouldn't worry about that being addictive as well, as long as you take it just at nighttime. What you can do is just to find the minimally effective dose. So that means if you're taking a higher dose, try to decrease the dose and see what is the dose that would just allow you to sleep well during the night with the least amount of side effects, because it is a bit sedating.
And you know, that's a term that we use almost every week, which is the minimal effective dose. I think, you know, particularly in America, we have this idea more is better, bigger is better. You know, and ideally, you want to take the minimum dose of anything that is going to give you your effect. I mean, obviously, if it's not effective, then, you know, it's not effective and you need to go up. But why take more if you don't have to?
I agree.
Okay, next question from Danny. I received a single lung transplant as a result of IPF, interstitial idiopathic pulmonary fibrosis, 4 weeks ago this coming Friday. Congratulations. With all the anti-rejection drugs I am taking, I find sleep very evasive. Any thoughts on a solution?
Yeah, that's a complicated one. A lot of those medications cause a lot of issues with insomnia, and we've seen a lot of patients that, you know, at some point when the dose may be able to be reduced or the medications adjusted, the sleep tends to improve. So again, discuss that with your doctor, and perhaps a sleeping pill may be of use during this period.
I mean, I would think also, we're only 4 weeks post-transplant. I mean, maybe it's the meds, maybe it's just that you're 4 weeks post-transplant. I mean, I'm sure pain is an issue, or maybe it's control, but I would think there's a lot of factors there that could really, you know, affect sleep.
Right. And acute use of medications for sleep sometimes can be beneficial.
Okay, what about, here's a bit of a long question, but I'm going to try to hit it and say it fast, because it leads to something that I think is important to everybody. I was treated for MAC 4 years ago with antibiotics, have sputum samples have been negative for the past 2 years, but I'm still fighting valley fever, okay, which I contracted shortly after being diagnosed with MAC. Was advised to sleep upright in an adjustable bed to prevent possible backwash from this. This is a complex question. This is going to have every system in it. But to prevent possible backwash from the GI system into the lungs. So we're talking about reflux based on symptoms I reported that indicated a probable hernia. And probably we're talking about a hiatal hernia here.
Right.
So however, sleeping upright has entailed back and neck pain, resulting in interrupted sleep and over the long-term sleep deprivation. Sometimes I wake up after 4 to 5 hours but can't go back to sleep. So I get up and do 1 to 3 hours of activity, then go back to bed. Okay, if I'm sitting on my side as if sitting up with my back supported and almost, okay, so I do get up, then go back to bed, and I can go back to sleep if I'm on my side as if sitting up with my back supported in almost a fetal position. The problem is that I'm taking posaconazole, which I've never heard of, but that's for the valley fever, is causing edema in the feet and ankles. Sleeping, sitting on my side aggravates the edema. Okay, so this is a complex question. It has pretty much hit every system, but it leads me to, let me try to simplify this, because this is really a very specific question. But let's talk about sleep position. Is any position better than others, and for what? And maybe you could talk just a little about the GI system and reflux, and also secretions.
So the best position, if you just take human nature, is where you feel comfortable with. You know, most people tend to be side sleepers, but people can feel comfortable in different positions during the night. And it's very important once you identify a position you like to sleep in to always remember that an alignment of the spine is important, because a lot of we're talking about, and the question brings up neck pain, back pain, you know, lumbar pain. Because if you sleep with, sometimes we spoke about in the past about pillows, you know, if you sleep with a pillow that is not supportive and you sleep on your side, the neck may be tilted and it causes problems. Now, so comfort is number one. I think you have to find a comfortable position. The second important thing to remember is that we move at night.
Okay.
We move probably at least once an hour. So whichever position you may fall asleep, you may even wake up on that position, but you move during the night and you'll be landing on your back, on your side, and your stomach perhaps. So it's important to keep that in mind, that just trying to sleep in one firm position during the night, it is very uncomfortable for the joints. And that's where we have a lot of people that are only side sleepers. They may have issues with shoulder pain and hip pain, and if the mattress is not supportive, it can be an issue. If you're more of a back sleeper, what we always worry is about the airway. The orthopedics tend to like the back position because, again, the alignment of the spine is really great. But at the same time, let's say sometimes you have people recovering from spinal surgery and they have to lay on their back, it's a problem for the airway. So sometimes a little bit of an inclination, as we saw on that question, of the head of the bed can be beneficial, because we're talking about GI specialists.
Right.
They like the head of the bed elevation, because that will decrease the amount of the reflux. Just by pure gravity, the stomach will sit lower than the esophagus, where the airway here is, and then the reflux, even if it's still happening with that hiatal hernia, is not traveling upwards, because the gravity will keep it from doing it. So it's important to put all of those into one formula that would work effectively. In different phases in our lives, we may have to make adjustments and find different positions that will be beneficial for the sleep.
Gotcha. And Hannah, you know, Catherine, I mean, what makes your question so difficult is that you're talking about the GI system. So obviously, you know, the position that's going to help the reflux might be, you know, less beneficial for the edema in your legs. Or the position that's going to, you know, help the edema in your legs, which is legs elevated, head down, might affect, you know, somebody with congestive heart failure or something like that. So, you know, this is really a balancing act, and, you know, what you're seeing is that gravity plays a huge role, and it plays a huge role in terms of fluid. So when we're upright, gravity is going to bring fluid to our legs and increase the potential edema. For anyone with congestive heart failure or pulmonary hypertension, a head down, legs elevated position is going to increase venous return to the heart, and that's could potentially, you know, increase the workload and make it harder on you. And also, when we talk about secretions, which is something that we talk about a lot, and here comes a shameless plug, get ready. In 2 weeks, Marion Mackless and I are going to be talking all about secretion clearance, and we're going to talk about positions. But for the patient that reports that they cough a lot during sleep, okay, why is that happening? Because when you're going down, gravity is again bringing secretions up to where you're coughing them up. And so you say, well, I couldn't sleep all night, I was coughing, and that's where an airway clearance program really comes in. But again, your question is so complex and individualized, because you have multiple things, and what helps one may not help another. If it was just reflux, it would be easy. It would be sleep on a wedge, or, you know, if it were just edema, it would be easy. It would be elevate the legs. But in your case, it's a balancing act where you really have to talk to, you know, your pulmonary doctor, your cardiovascular doctor, and maybe even a vascular or peripheral vascular doctor to help you work that out. Next question. So from Alfred, I have sleep apnea and have been using a full face mask, CPAP, religiously for the last 19 years. About 9 months ago, I started waking up with severe dry mouth. A sleep study can confirm that my jaw would open after I fell asleep, and I would breathe through my mouth, causing the dry mouth. I tried numerous chin straps to no avail, so I have been sleeping on my side, which helps to keep my mouth closed, but I prefer to sleep on my back. What do you suggest to keep my mouth closed while I sleep?
That's a very interesting question. So when we're talking about comfort, so let's say you found a mask you really liked, which is great. So the interface, which is a different size of and different models of masks that are used, are very helpful, and they all target that back of the throat. Now when the air travels through the mouth, even if you're not leaking air outside, it's just the CPAP pressure, let's say, going to the mouth, that can cause a lot of dryness. So the major recommendation has been to add a humidifier to your CPAP machine, because the humidification, although it doesn't do anything for the treatment, it works well for comfort.
So they don't all have a humidifier on them?
Most of them nowadays come with a
Okay.
humidifier. In the past, you need to add on. Now the latest models really come with a humidifier embedded into it, which you could remove and close that opening. But what is very interesting is, as well, with technological advances, the other change that has happened is that now the humidifiers have a different hose that has, some of brands have now a copper coil to it. So they are able to maintain the heat in the hose and maintain the humidification at a certain temperature that becomes not only comfortable to breathe in, but may alleviate the issues with dryness in the mouth. So that's another possibility into looking into this. And I think the other important point is that the mouth, if there is any leakage through the mouth, as long as it's not adversely affecting the treatment, I wouldn't be too concerned. But this seems to be more of a comfort issue.
Comfort issue, okay.
That. So trying different levels of humidification, I think, would be very interesting. And the new heated hoses.
What about a general air humidifier? Do you recommend that to people?
Not really, in honesty. I'm a bit skeptical about, because of the issues on infection control and keeping well sanitized. I'm very concerned.
Okay, interesting. So if someone comes to you and says, my room is so dry, you don't recommend that?
Not necessarily. We have to, open windows, try to have fresh air. I think we have pretty decent humidity levels in the air, particularly where we live. In some other areas in the country, it may be very dry, so perhaps in a very dry environment.
Gotcha. Okay, here's a statement. I don't know if it's a question or a statement from Roger. It says, we must keep our oxygen level over 90, preferably over 93, at all times, in all caps, day or night. So you said 88?
Yeah, so traditionally we have been looking at 88. If you look now at all the resuscitation efforts, so when we do CPR training and all, they are looking at 92 as the cut down point.
Okay.
So perhaps people may have different conditions that have been looking at, but when this number comes usually close to 90, because when you look at the hemoglobin, the saturation curve, we have this relationship between hemoglobin and oxygen saturation. And we can see people may have different curves, and that curve may shift to the right and left. So we want to look at an optimal amount for oxygen to be present in the body to be delivered to the cells. So that's the indirect measurement that we look
Gotcha.
at. So that curve may be shifted a little bit. So having a range, I think it's perfectly fine, for several people to maintain that at levels 93 and above. But sometimes it could be a different cutoff.
This is something that I hear people talk about a lot, and I always find it a fascinating thing, because I'll hear people who, and again, we're talking about the oxygen hemoglobin dissociation curve, and what Dr. Krieger is talking about is this is sort of an S-shaped curve where kind of we've always thought that 90, like between 90 and 100 is about equal, but 90 is like a cliff, where if you go to 89, you go over the cliff. But I always say to people, well, you have to take into account, first of all, the fact that pulse oximeters are going to have a plus or minus of 3%. So if it says 89, maybe you're 86, maybe you're 92. But also, I hear people talk sometimes and they'll say like, well, my doctor said I should be 92, but not 93. And the odds of you actually really being that exact number, I think, are so small. And I don't think there's, my personal feeling is that there's no one's going to really suffer by being 94 as opposed to 93, except maybe the CO2 retainer, who has to be particularly careful.
Right. And I think the other aspect we need to take in consideration is that if you look at the whole physiology of lung function, as we age, that gradient between the air that you inhale and the air that is really containing the oxygen in the blood cells is going to increase. So there is an aging effect on this curve as well, which is not directly on the curve, but is on the lung function. So we have a larger AA gradient, is what you call it.
Okay. Here, and this seems to be along the same line, so this is from Anne. For IPF, are you saying that the oxygen should be set lower than the daytime level? So I guess we're responding again to the fact that you said 88%. If sleeping, how do you know your oxygen level when you're asleep? I was tested for sleep apnea and told that I didn't have it. I can't tell, so just read, okay, so again, I think people are responding to the 88 number that you said.
So I think the other important, again, talking back into physiology, is the fact that our physiology changes during sleep. We started talking about the stages of sleep, right? What happens to the body. So one of the aspects of the physiology is that when you go into sleep, by changing on the normal ventilation, talking about a normal individual, somebody even without any lung disease, So there is a decrease in oxygen and increase in CO2 during sleep. And
Anyway,
that's
no
part of
matter
the
what.
normal physiology.
Okay.
So this is why the fact that the acceptable numbers during the daytime may not be always applicable for sleep. And that's why sometimes people say during the daytime, we don't want anybody below 90 during the daytime. We have indications for oxygen that cut off below 88 for certain minutes during the daytime, depending on the insurance company. So it's the same criteria that we use for sleep. But we just need to be mindful that everybody, when you look at the oxygen curve, daytime and nighttime, you can see that there will be a decline during the nighttime.
So your answer to that wouldn't be to just take a little more oxygen at night?
Not necessarily.
Okay.
Not necessarily.
Okay.
If they are on oxygen, people that are oxygen dependent, and they use oxygen during the daytime,
Right.
yes, so they would increase their oxygenation at night because they probably need a higher level.
Okay. I'm not sure if I think I asked you this before, but I'm getting I'm getting senile. But is somebody with IPF or is restrictive disease versus obstructive disease more prone to a sleep problem than others? Is one more prone to a sleep problem?
Yeah, so restrictive lung disease tends to have more of the ventilatory aspects that we're talking about throughout the night.
Because they're not doing the extra work to breathe?
Exactly. And then the obstructive disease, they tend to get into trouble, particularly during REM sleep, because that's where then the diaphragm, which has been compensating a lot with people that have COPD, really is the only muscle working.
Gotcha. Okay. Okay, next question. I read Kindle books at bedtime on a tablet. Is that screen bad for me?
It depends on the Kindle. There are some Kindle books that have very, very low light. They're more like a paperback, and that should be fine. If you have a Kindle Fire, which is basically has the same light as any of the other electronic device would, so that would be not advisable. Now, keep in mind, a lot of the recommendation things that we spoke about really are applicable for people that have problems. If your sleep is perfect, I don't normally advise people to change what they are
And
doing.
it probably depends what you're reading. So if you're reading something really steamy, you might want to stop reading a little bit before bed. Or also something scary.
Yeah, we like poetry at night.
Okay, poetry, there you go. Also, I think most of the devices, you can also adjust the brightness. Does that help it as well? Or is it?
Yeah, a little bit. Some devices you can reverse the color as well, but I think I usually recommend if they are going to use a device to use some type of surface to block that blue wavelength, and if you use, even in computers, there's specific software that can really reverse the color.
Gotcha. I take 500 milligrams of magnesium before bed to help restless leg.
Yeah, that's good.
That's my
I think
friend
it
out
works
there,
for a lot of
Sharon.
people.
All right. Anyone else finding audio and video out of sync? No? Okay. Just one thing while we're on that topic, it's not sleep related, okay? But a lot of times when people say that, okay, if you're having an issue like your audio is out of sync, and you don't, you feel like you're watching one of the old Godzilla movies where they say Godzilla is coming, that usually doesn't have to do with what we're putting out, okay? We know that we're putting out a good signal. It usually has to do with the device that you're using, and if you are having that problem, please email me, and Chris, our sleep technician, and our other guy will work this out for you. Okay, thank you. I got on late and got a bit, okay, next. How do you deal with the anxiety with the mask?
Well, again, we need to figure out what is causing anxiety.
Okay.
So we've had people that have anxiety with the mask just because of other past traumatic exposures, people that may have had issues feeling suffocating or not. There are different masks. Nowadays, very small masks that serve, we call them nasal pillows. They sit right here almost as a little mustache. And the latest model even just has an elastic headband, so there are no other attachments that you're even able to visualize, which is very important because sometimes the anxiety comes from looking at a surface that is just right in front of your eyes, and that creates a lot of stress.
And are those available to everybody?
Oh, yes.
So if okay, so that's good to know also. And I think what you're talking about, we have the NIOV, which is and that really is very effective. But I think a lot of times, and especially depending upon where you live, okay, I know a lot of my people come from small towns or places where, the oxygen or CPAP supplier may have one device,
Right.
and they're not really that inclined to get you, do what they need to do. But people have a right to ask for these things, right?
Always, and I think the other importance is that, let's say you have a computer or some type of device, and that's why you're getting this information. Go online and look for what is available, and you can talk to them as well. Sometimes you might even be able to ask them to send you samples and other equipment that you might be able to use.
I'm going to also give another plug. We talk a lot of times about anxiety, and anxiety is a huge issue with cardiovascular and pulmonary disease where people get short of breath. And of course, there are a few things that in life that are more anxiety provoking than not being able to breathe, but we know that that creates a lot of chemical reactions in the body that then makes you more short of breath. A few weeks ago, and I talk about this webinar all the time because I just love what this guy was talking about, but we had Dr. Richard Brown on, and he talked about his breathing techniques. And I'm going to tell you something, these breathing techniques are so great for anxiety, and he talks about the idea of balancing out the sympathetic and the parasympathetic nervous system. And a lot of what you were talking about, we didn't talk the sheer scientific physiology of it, but we're talking about the sympathetic nervous system being overloaded, right?
Absolutely. And we use a lot of the techniques he talks about, the coherent type of breathing. There are even apps that people may use freely in order to try to synchronize the breathing, because the rhythm of breathing is very important.
Right, and I would recommend the deep breathing techniques to people all the time. And can those also, it sounds like those can also be used with the BiPAP.
Yes, absolutely.
So, okay.
With sleep.
And those can be found at www.pulmonarywellness.com. And again, I don't mind shameless plugging because, hey, it's my show. And second of all, we're not selling you anything. So it's there for you for free. Go on our website, under web archives. All of them are there. Here's another question. This is a great question. This is me. I go to sleep very easily, but only sleep 2.5 to 4 hours. Then I'm wide awake for the day. How can I sleep longer?
So there are a couple of mechanisms that happen that wake people up. Sometimes there is some underlying stress and anxiety that after you get through the bulk of that pressure for sleep, you may wake up. So that's one of the mechanisms we're trying to analyze. The other aspect that would be interesting sometimes that play in patients with this is if there is any concern about sleep apnea. The bulk of the REM sleep, remember we spoke earlier, they get dreaming cycles, we sleep in cycles, and the last few cycles have a lot more REM sleep. REM sleep is a period that in order to keep us from acting out our dreams, which sometimes people do and it's a problem.
Sorry.
We are not asleep.
That's true. Are you sure?
Yeah, that was intentional.
Okay.
So we release hormones that then relax the muscles a little bit more. And imagine we're already talking about an airway that may be compromised during the sleep. So once the muscles are even more relaxed during REM sleep, a lot of the sleep apnea may surface. So we have to make sure that that's not a manifestation of sleep apnea that is just bouncing in during REM sleep, which happens after a certain time of the night in much larger duration.
So that could be a sleep study person. That person should have a sleep study.
You could. And also I would say talk to your doctor, because there are issues in there that relate more to stress, anxiety, busy day. That we always have a lot of anticipatory anxiety. Let's say a big example, if you have an early morning flight to catch, you're going to ruin your sleep. You can't really sleep until the alarm goes off, right? But sometimes we have low level of stressors that are present, and that's what is surfacing during that early morning hours.
Is the later sleep more valuable sleep? Because it sounds like what you're saying that this person may be missing out on a lot of their REM sleep.
Well, anytime you wake up, and you cut your sleep, you wake up before you complete your cycle, you're missing out on REM sleep.
That resets, so you have to go back through the whole thing again?
Well, the body is very resilient and tries to compensate for that as much as possible.
Okay. I sleep 2 to 4 hours a night. If I get more than 6, I feel terrible all day. I don't know why, but I feel exhausted.
Short sleeper?
I'm up almost every hour, but I sleep,
We'll talk more off record.
But what I do, I'm going to give you a suggestion. If I wake up and I'm wide awake, I do something. I won't lie in bed. There are people who say I've been lying in bed, but I'll get up, I'll paint, I'll write, I'll do something. I won't stay in bed saying like, oh, I wish I was asleep right now. I'll get up, I'll do something, I'll take my dog out. That's the next show, but that's going to be a long one. Okay, so here's the next question from Sharon. On some days I get tired. Oh, this is a great topic. This is going to be very interesting. On some days I get tired and take a nap at the later part of the day, around 3 or 4 p.m., and end up sleeping 3 to 4 hours. everybody says my body needs it to heal. I'm concerned when I have not had a very busy day, maybe a shower and a load of laundry. Should I worry? Let's talk about naps. That's a great question right there.
So naps, I think, can have a benefit. And culturally, in some areas in the world, we have people that are nappers. They close for business in the afternoon, right?
Siesta.
Yeah, right. Here it's like impossible sometimes for us to even think about it. But sometimes people that are very sleep deprived, they need to catch up with sleep at some point. So the nap can serve that purpose in allowing people to catch up with sleep. The only concern that we need to keep in mind is that you don't want to make the naps very long, because very prolonged naps is almost like having dessert before dinner. You're taking away from that pressure of sleep. So when the sleep cycle tries to kick in, you already had some of your sleep paid off. So we try to keep naps usually as a recommendation about 20 minutes long, but not much longer than that.
Power napping.
Yeah, a little less. Power napping, I think they actually are even faster than that.
Okay.
But I think I would keep, at most 20, because of the cycling of sleep, talking about the chemicals again that control sleep. Once you get into a longer period, you start having full cycles of sleep. And the longer your sleep is, then the more REM sleep you have, and the less awake and alert you will feel sometimes after you wake up. There's this phenomenon of sleep inertia, which means shortly after waking up from a long nap, let's say, or even a long period of sleep, your brain is not totally alert. So that's, again, a chemical process, and slowly all the other alerting hormones will kick in.
So set an alarm for a nap, too.
Yeah, I would say, ideally, you should have your nighttime schedule set up in a way that you will be able to sleep, because if you're able to take 3 or 4 hours of your afternoon to sleep, perhaps you could add that to the nighttime and work through until sleep comes at night. Not everybody is able to do that.
Gotcha.
But it can serve a purpose too. Sometimes you see emergency room physicians that have a crazy schedule. They may have, sleep in different times of the day, and they may follow their own sleep schedule with naps all the time to compensate.
Question from Vladi. BiPAP is sometimes considered a ventilator. It is recommended for patients so I'm not sure if this is a question, is it or it is, but I'm going to say BiPAP is sometimes considered a ventilator. It is recommended for patients with high CO2 retention. How do you feel about that? Also, how do you feel about automated CPAPs, which adjust to patients' airflow needs? Are they good for everybody?
So starting with the BiPAP, yes, it is considered a ventilator because of the ventilatory mode, and what ventilation means is that you try to allow air to go in and out. So it is. Now, for insurance purposes, as long as you don't give it a backup rate, so as long as you're not breathing for the patient, because that's what the most ventilators that will do in a hospital, if you don't breathe, they breathe for you, or sometimes they always breathe for you if you're sedated. So you're correct in calling that as a ventilatory mode. Now the auto-CPAP machine, so different manufacturers have different algorithms, and what they have created over the years are machines that will be interpreting your airflow. Remember we spoke about airflow and having the breathing events, and once they see that the breathing is shallow, the machine itself will automatically increase the pressure in it. I have kind of dual feelings about that, because for once I think it can be helpful, but at the same time the algorithm tends not to be perfect. So sometimes the machine may be sensing, let's say you change your position, you took a bigger breath, and now the machine feels that, oh, you don't need any CPAP anymore, let me decrease the pressure.
How often does it make adjustments?
Depending on the algorithm, they could be looking at a breath-by-breath analysis, and if you have 2 or 3 abnormal breaths, it may increase the pressure.
So wouldn't that adapt, though, once you go back to normal breathing?
Right, but it can also disturb sleep, and that has been the biggest feedback that we had from patients saying the auto-CPAP, the adjustments, sometimes the machines are very quiet, but the pressure, you may hear even the changes in that. Now, there are some people that can really benefit from this, and there are patients that have either positional apnea, as we spoke, people are on their back and they have apnea on their back, and if they turn to the side, the apnea is much improved. Having an auto-CPAP machine would allow for that adjustment to happen. And in other patients that have more REM sleep-related apnea, that adjustment can also be helpful. So it's not for everybody. I don't recommend it personally to most of the patients that we see. Most people do well with one pressure setting, but many patients can actually benefit from it.
Gotcha. That's great info. Next question. I don't have sleep apnea. I sleep well. I've been diagnosed with moderate COPD, but I have not yet begun using an inhaler. I'm studying, learning a lot thanks to your webinars. I am a side sleeper, falling asleep watching TV many nights. When I awake, my shoulders and neck are very sore, leading me to think that I may lift my shoulders during the night, possibly to take in oxygen. If I could learn to sleep on my back, would that make it easier for me to take in oxygen? At this point, back sleeping is not an easy thing to do. P.S. I'm 72 years old and have a mitral valve replacement 5 years ago. The only meds I take are furosemide and Synthroid, if that makes a difference.
It probably wouldn't make a big difference. I don't know how your body weight is, but sometimes for people that are a bit overweight, sleeping on your back can be worse because it's a worse position. All the gravity also pulls the fat in the abdominal cavity and pushes on the diaphragm, so it's not necessarily better trying to sleep on your back. What you could try to do is just to see if you have somebody observe you when you go to bed and try to look at the alignment of your shoulder and your neck. Because perhaps if you can just move the shoulder a little bit and find a very comfortable pillow that will really cover the distance between your ear and the mattress, will be very important to have an adequate support, because it may be more of a support issue.
Yeah, I was going to say the same thing. I think a lot of times when people have like COPD or heart disease or pulmonary fibrosis, then they start to attribute everything to it. And they say, is that my COPD? And I mean, it makes sense because we talk about the fact that, when your diaphragm is impaired, you use the accessory muscles a lot. But the fact of the matter is when you're actually lying down, it changes the whole mechanics of it. So that is no longer even valid because we've eliminated gravity. So that's actually a little bit different. But I'm somebody who used to have a lot of neck and back pain when I sleep. I think that has a lot of times, what you have to realize is that in between here and here, so all the nerves that come out of the neck, those affect the arms. So those are the nerves that innervate the arms, and all the nerves that come out of your low back are the ones that innervate the legs. And I think a lot of times when people say, I wake up with neck pain, or my arm is asleep, or I have, pins and needles when I sleep, I think the key to that is finding the right pillow. And there's so many different ones out there. And I can tell you, I've gone through like 11 different pillows, and I finally found one, and I don't have neck pain anymore. Like water pillows, air pillows, just keep trying them, because there's that is a really individual type thing, So I wouldn't attribute that to the COPD necessarily. I would really attribute that to more of an orthopedic issue. Next question from Al. I have COPD and alpha-1 with an FEV1 of 22%. I try to keep my saturation level very close to 98%, even being on O2 24/7. I look at keeping the level high 98% versus going down to 94, and my reasoning is, why have these major organs of my body be at less than peak performance levels? Any reason not to continue my way of O2 saturation percent?
Not necessarily, and it sounds like you're probably very young, and definitely younger people, we want to have higher levels of oxygen saturation. Again, we spoke about the age and the gradient in the body expects more oxygen. So I think if it's working for you, I don't see any reasons why you would be retaining CO2, which is again the concern of over-oxygenating the body. I think if you're well treated with that, I wouldn't advise to change that.
Okay, now Al, one other thing is that we talked a little bit about the oxygen hemoglobin dissociation curve, and what I think the point of that curve that people don't realize is that there's not a great difference between 95 and 98 in the blood, right? So like, again, the top of that curve, and if somebody reminds me, sends me a Facebook message, I will post I'll post that curve of very simply, sorry about that, I don't mean to reach, but I wouldn't, all right, so just very simply, essentially what we're saying is that the curve is S-shaped, and so if we say this is 90 and this is 100, this is all about the same. So, again,
so this is the saturation in here, and this is the amount of oxygen.
Right.
So that's what he's telling you, that once your saturation level goes up, the amount of oxygen in here really doesn't change in the body.
So that it's not that different. I think people.
So the organs are not being deprived of oxygen.
Exactly. So you're at 94%, you don't have to worry that your heart is not much happier at 98% than it is at 94%. It is a lot happier at 98% than 88% or 78%. But that's a good question too. And Al, if you want to get back to us and tell us your age, we'd be interested about that. Yes, audio is out of sync, and then it names a major phone company, and it says they stink. But being that we don't want to get sued again, we will not name them. Okay, next from Guy, sleep study. I was told you have to sleep 6 hours to get a good read. Okay, so this is about a sleep study. I was told you have to sleep 6 hours to get a good read. I only sleep maybe 4 hours a night, get 3 to 4 times a night, get up 3 to 4 times a night to go to the bathroom. How can the sleep study help me? Can you get a good sleep study with that?
Yes, because there is an aspect of that transition into sleep. Sometimes people may be on the electrical activity already asleep, but you may not be able to perceive that as sleep, and that's what we spoke earlier on about the transitional stage 1 into
Okay.
sleep. And the other part of that is that, again, remember that we sleep in cycles, so the idea is that the longest duration that we can get on this overnight study, the more sampling of all the different cycles we'll have, so the more accurate the data is, because all the data is indexed based on the sleep you had and the cycle of sleep you had. But I don't see that being a problem for you.
They'll still get an accurate study. They'll find out data.
Yeah, sometimes we have people in 20 minutes into the sleep study, we say stop it because they have severe apnea and we need to start treatment with CPAP.
Okay, good to know. Should I set an alarm to sleep less or sleep earlier? Maybe. I think we're talking about the nap. Al just got back to us. He's 65 years old. So that's the person who...
That's a pretty good situation.
Here's a question. Do you just try to ignore being tired and keep busy and try to go to bed early after dinner?
Again, keeping a regular schedule. You don't want to go to bed too early. Most of us are tired in the evening, and some people even feel a second wind before going to sleep. But if you try to keep that schedule synchronized, avoid the dozing off, watching TV, or doing something that will allow you to doze off, and then next thing you know, you slept for 20 minutes, sometimes 2 hours, and then you have difficulty falling asleep. So that's what we call that sleep hygiene, is that behavior approach to sleep and trying to synchronize your cycle.
The body likes consistency.
Yes.
Okay, couple more questions and then we're going to run out of here. My chiropractor also helps and also a massage. Okay, next, thanks for your pillow suggestion. Can you tell me the type pillow that has worked for you? It's actually a Mickey Mouse pillow I got in Disneyland. No, I'm just kidding. I will post a link to a few of the different pillows that I've tried. I've tried a lot of them. But one that really helped me was a water pillow where you fill it up with water, and that helped a lot. But I will post a few that I have tried. Okay, I think that is the last of the questions. We have, Chris, do you have any more questions? We have 2 minutes to go. I'm only going to use 30 seconds of them. As you know, we have a tradition here at the Ultimate Pulmonary Wellness webinar series, and this is for Dr. Krieger. I thank you. You notice you could not find one question that stumped her even for a second. She just got peppered for a good 40 minutes and picked up every ground ball that came at her. So I thank you so much. This was super interesting, fascinating, and I thank you all for signing in tonight. Just to let you know, the upcoming, this is for you, and if you want, we will send it to your office tomorrow if you don't want to take it on the train or bus. You're very welcome.
Does it look like me?
I think it does, but I'm biased because I'm the artist. We try to make people more colorful. Just a little scheduling update. So in 2 weeks from now, Marion Mackless and I will be talking about everything you want to know about clearing secretions, aka mucus. 2 weeks after that, we're going to have superstar respiratory therapist laureate of the world, Mark Mangus. We are flying him in from Texas to talk about every single thing related to respiratory disease. And this is going to be like Pacquiao, Mayweather all over again, because Mark and I have some differences of things that we're going to talk about, but we're going to hash it all that night. Probably one man or neither man will be left standing. And then after that, we're taking a 3-month break until September, at which point, if you want to get me, you're going to have an underwater microphone. And that's it. So I want to just also tell you all about my Facebook group, our Facebook group, which you are welcome to join. It is called Breathe Easy, Ultimate Pulmonary Wellness for All, and if you can't find that, just go under my name and friend request me and ask me about the group. If you don't know my name by now, please don't watch any more of my webinars, but it is Noah Greenspan, and that is it. So thank you for signing in. See you in 2 weeks with Marion Mackless. Thank you again, Dr. Krieger. This woman cannot be stumped. Good night.
Thank you. Good night. Thank you all.
All right. That was awesome. Chris, are we off? That was great. The questions really got to, you know everything about sleep. I have that figured out. So thank you.
I love this.
Well, enjoy it. So